the LGBTQIA plus community. I think this is going to be a really great conversation this morning. So just to get us started, I wanted to show you this slide about our control panel. So if you look at the bottom of your screen, you can see on the left-hand side that there is a button to mute or unmute yourself. You can turn on or off your video. You can see who the participants are in the side panel. There's also a chat side panel that you can use, and please feel free to use the chat anytime that you need. Anytime you have any questions or thoughts that come up, we're really open to having you share those questions with us. You can also enable closed captioning by clicking the closed caption button at the bottom. And as a reminder, this webinar is being recorded. It will be uploaded to our resource library by tomorrow so that you can check out the recording if you'd like to return. You can also share the recording with other folks. Again, this morning, we're going to be talking about health equity in the LGBTQIA plus community. Our presenters are Alexia Sambrano and Dr. C. Burton. We're really excited to have them to talk about their perspectives on health equity in the LGBTQIA plus community. So the first thing that I'd love to do is to have our land acknowledgement. So we acknowledge that we are in the traditional territory and homelands of California Native peoples. These nations include over 120 federally recognized tribes and many other non-recognized tribes that are all very culturally diverse. We thank these nations for their generosity, and we keep them in our hearts and thoughts as we are in the space today, this week, and every day. So you can go ahead and use that link in order to find out whose land you're on, if that's something that you need to do. So next we are going to do our opening circle. And so it would be really wonderful if we could get the folks in the audience to type in your name, pronouns, agency, location, and land acknowledgement. If you can do that for us, that would be really great. So we can get to see who's in the space. The next thing I'd like to do is introduce our prevention team at the partnership. Team, would you like to introduce yourselves?
Sure.
Anybody?
I can get us started. I already put myself in the chat just in case. I'm Kimmy Remus, everyone. I use she, her pronouns. I am a prevention specialist at the partnership with Melody, and I am calling in from Susquehannock, Piscataway, and Nantego lands. And I'm happy to be here today. Miranda, I'll popcorn it over to you.
Thank you and welcome everyone. My name is Miranda Stiers. I use they, them pronouns, and I'm the Associate Director of Prevention at the partnership. And Jennifer, I will popcorn it over to you.
Thank you, Miranda. Good morning, everyone. My name is Jennifer Khalifa Ponce. I'm the Senior Director of Prevention at the partnership. I am here in Orange County, California on Tongva land, and she, her, and hers are my pronouns. Welcome.
Thank you, team. Appreciate your support this morning. So we're going to go ahead and get started. I am going to pass this over to Alexia. Alexia is going to get us started with their introduction to us about the LGBTQIA plus community. So Alexia, I'm going to pass it on over to you.
Awesome. Do I have share screen privileges?
You should. If you don't, let me know.
Okay, let me try it. Can folks see my screen okay?
Yes.
Awesome, thank you. All right, well, thank you for having me, folks. Like Melody said, my name is Alexia Sambrano. My pronouns are they, them, theirs. I'm a violence prevention educator with the University of Southern California in their Relationship and Sexual Violence Prevention Services unit. I put my email there on the screen, both my USC email and my personal email, if anyone would like to stay in contact after this, if they have any questions. I'll have my email at the end of the presentation as well. but I'm going to be discussing trans healthcare specifically. So when I say the word trans, I'm referring to all gender expansive folks. So trans, non-binary folks, gender non-conforming, etc. So what we're going to be doing with this presentation is really looking at how anti-trans violence manifests in our communities and how we can unpack that, and taking a look specifically at the pathologization and medicalization of trans folks and their history with the medical field and medical professionals. But before we get started, I also have a land acknowledgement here. So I'm going to read it out for folks. So we acknowledge that in Los Angeles, we're occupying the unceded land of the Tongva Gabrielino people. It's important to call attention to the history of settler colonialism and the ongoing struggles for justice and recognition of the living culture of the Tongva Gabrielino people. As individuals who strive to work for dismantling supremacist systems of oppression, we are committed to naming the people of the land and continually addressing our own privileges and internalized colonizer thoughts and behaviors. With gratitude and humility, we honor the elders, the stewards of this land. Okay, thank you, folks. So in this presentation, what I'm really hoping to discuss with you all are these three broad topics. The first one being this epidemic of violence against trans folks. So what exactly we mean by violence, how violence manifests in these communities. And so this includes anti-trans stigma, denial of opportunities, and then increased risk factors that might put trans folks at risk when they're experiencing anti-trans stigma, and how this kind of works as a cycle. So this will be the first thing that we'll discuss together today. The second being kind of a big brief crash course. Obviously, we know there's tons to talk about when it comes to trans and gender expansive healthcare, but a brief crash course on this. So we're going to talk a little bit about the history of trans pathologization and medicalization, and how we can move towards a gender inclusive framework for trans healthcare. And then finally, we're going to talk a little bit about revolutionary thinking and how we can incorporate LGBTQ+ liberation in our work. So moving forward, we're going to start with discussing the roots of anti-trans violence, so this epidemic of violence against trans folks. And I would like to preface before we jump into anything that if at any point you feel uncomfortable or activated by anything that's said, you need to take a moment, definitely take care of yourself, do whatever it is that you need to do to preserve your space and your well-being. Okay, so here on this first slide, I'm going to be talking a little bit about that epidemic of violence against trans folks. So what exactly, nationwide and worldwide, what this looks like. So here in the US, we actually rank third in the world for trans homicides. So this is after Brazil and Mexico. And in 2020, the Human Rights Campaign tracked 44 fatalities due to violent fatal incidents against trans folks and also gender nonconforming folks. So genderqueer folks, non-binary folks, folks who exist, their gender exists beyond this gender binary. But even though this was the only number that was tracked through the Human Rights Campaign, specifically within the US, there are likely tens to hundreds more that are unreported, untracked, that are still associated with anti-trans violence. And this is also obviously not including, violence that occurs that is not fatal. So what does this tell us? It tells us that there's a clear pattern of, fatal violence that disproportionately affects trans women of color, and in particularly Black trans women. So what does this suggest? This suggests that there are a lot of intersections with gender. Racism, sexism, homophobia, biphobia, transphobia are also at play when we're discussing understanding violence against trans folks, right? Every single trans person is not going to experience their journey with their gender identity and the way that the world sees them and treats them the same, right? Violence affects different communities and different folks with different identities in vastly different ways. So we're going to talk a little bit about that. What leads to this violence? How are these issues exacerbated by all of these systems of oppression? So I mentioned at the beginning when I was going through what we were going to discuss, that these kinds of work in a cycle. So I mentioned we would discuss anti-trans stigma, denial of opportunities, and increased risk factors. So all of this they work together, and you can't really have one without having the other, and they're compacted and they are exacerbated by one another. So anti-trans stigma will lead to increased risk factors of experiencing violence and will also lead to a potential denial of opportunities in their day-to-day lives. We'll talk a little bit about what this looks like in the next few slides. And then these increased risk factors lead to higher rates of these higher rates of lead to reinforcements of these stigma and false narratives about trans folks that then, continue that cycle over and over again. So we understand that these issues are intertwined with and exacerbated by different forms of systems of oppression that work together to create anti-trans violence and to stigmatize trans identities. So when we're looking at anti-trans stigma, we're looking specifically at the way that people are treated both interpersonally with other folks and as well as, in broader communities worldwide. So for many trans and gender nonconforming folks, living openly can be its own act of defiance in a society that continues to set rigid cultural norms for gender identity and expression. And that act of defiance of living openly as yourself can be very empowering. But there are also barriers, right, that make life more difficult for folks who are trans or gender nonconforming. So the stigma that folks get because of their gender identity can erect barriers in virtually every facet of life, pretty much denying trans and gender nonconforming folks the equal opportunity to succeed and be accepted for who they are. So anti-trans stigma can have very long-term effects on health. So this includes mental health, and economic and housing stability for, just two examples of things that are widely affected by stigma. And this is especially true if individuals experience familial rejection and isolation from social support systems. So this is, what we're referring to when we mean anti-trans stigma. Looking at denial of opportunities, there obviously are a lot of ways that this can manifest. The first one being employment discrimination. So trans folks face disproportionately high levels of discrimination and harassment in the workplace. And these barriers are often even higher for Black trans folks, who have double the unemployment rates of all trans folks and 4 times that of the US population. The data here is from a survey from the Human Rights Campaign, and they found that 27% of trans employees report having been fired, denied promotion, or experiencing another form of mistreatment in the workplace due to their identity as a trans person or as a non-binary person. And the unemployment rate among trans folks is 3 times higher than that of the general population. So due to these employment discrimination, barriers, these denial of opportunities, trans and gender nonconforming folks are put at a greater risk of experiencing poverty, houselessness, and other situations that put them at an increased risk of violence and danger. Another denial of opportunity that folks experience are those who are trans but are also immigrants, refugees, and asylum seekers. So this is also true just generally for a lot of LGBTQ+ folks. So LGBTQ+ folks face extremely high levels of discrimination and violence in several parts of the world, right? In some parts of the world, it's still illegal to be who you are. And many come to the US to claim asylum and escape persecution based on their sexual orientation or their gender identity. However, even though they're hoping to come to the US for a better life, sometimes this is cut short when they arrive to the US. LGBTQ+ immigrants and asylum seekers face a higher risk of violence as a result of the US immigration system. So 40% of trans folks held in state or federal detention centers report being sexually abused during their time there. And LGBTQ+ people as a whole are 97 times more likely to report being sexually abused in immigration detention centers. Looking at healthcare specifically and social services, there are also denial of opportunities that trans folks experience in this realm as well. Trans folks are especially vulnerable when it comes to accessing social services and healthcare, including finding doctors who respect and affirm their identities. And many also experience discrimination from their medical providers, while others might simply struggle to access medical care and mental health services in the first place, or to have access to healthcare professionals who are knowledgeable of trans-specific healthcare. So nearly 1 in 3 trans folks say a doctor or other healthcare providers have refused to see them because of their actual or perceived gender identity. And then we also have over-policing in the criminal justice system. So I'll talk a little bit about this later on when we're talking about the history of trans liberation movements and LGBTQ+ liberation movements. But this is also another denial of opportunity and increased risk factor that folks experience due to their identity as a trans person. So due to the history of over-policing and discrimination and violence against trans and gender nonconforming folks by police officers and other law enforcement figures, many trans people, and especially trans folks of color, avoid interaction with law enforcement because they fear harassment, intimidation, incarceration, or violence. So among trans folks who interacted with police in the past year, and like I said, this survey is from 2020, NSA officers were aware that they were transgender. 58% reported facing some form of mistreatment from law enforcement, and 49% reported being misgendered. While 37% of trans folks who have been taking hormones prior to incarceration report being prevented from taking those hormones while incarcerated. So we see here already a denial of opportunity to access gender affirming care for folks who are trans and are also incarcerated, and as well as just general mistreatment from law enforcement. That particular survey from the Human Rights Campaign also showed us that trans people are nearly 4 times more likely than cisgender people to experience police violence, and also found that trans folks are 7 times more likely than cisgender folks to experience physical violence when interacting with police. In addition to all of those barriers that we discussed, there are also barriers to legal identification, and this also goes hand in hand with access to medical care. It might not look like it on the surface, but it definitely is connected in the way that folks have access to legal identification is oftentimes dependent on their access to gender affirming care. So trans Americans specifically face significant barriers to obtaining identity documents that accurately reflect their gender. This could be because of the state that this person lives in, that might have stricter laws on gender marker changes on IDs. Other folks might live in places where the requirements for having these changes are much more strict than in other locations. So this can include maybe having unnecessary medical procedures, like some folks are required by law to have undergone gender affirming surgeries or hormone therapy. Some folks might need some other form of medical documentation, court orders, or processing fees that might be, inaccessible for folks who are living in poverty or folks who are having a difficult time accessing gender affirming care, or healthcare providers who are willing and accepting to help them or accepting of them. So nearly 1/3 of individuals who have presented IDs with a name or a gender that didn't match their presentation reported experiencing negative experiences with other folks, whether it be in the workplace, police, in when accessing government aids or things like welfare, CalFresh. 68% of trans folks also said that none of their IDs or records reflected both their correct name and their gender identity. So a note on these barriers, right? We talked a lot about different forms of denial of opportunities that trans and gender nonconforming folks might experience. So we need to understand that these barriers do not exist in isolation from one another. They're confounded to produce a domino effect of rejection and anti-trans violence. So like I mentioned, having access to legal identification is also oftentimes reliant on access to healthcare services that are gender affirming. So for example, a doctor's refusal to provide trans healthcare might increase the likelihood that trans and gender nonconforming folks encounter problems with identity documentation, right? Sometimes they need medical documentation in order to get their ID changed. And then these issues with documentation increase the possibility that trans and gender nonconforming folks are denied housing, employment, social and healthcare benefits, and other services that they might be seeking. And then on top of that, these incorrect gender markers on identification increase the likelihood that trans and gender nonconforming folks are outed or exposed to violence and discrimination in their workplace, potentially in drug treatment centers and shelters for the unhoused and individuals experiencing abuse, and even in prisons. So these issues are further exacerbated by other markers of social status, like as we mentioned, race, class, ability, etc. Then finally, for this section, we're going to go over some increased risk factors. So this also goes hand in hand with everything else that we've been discussing, right? All of these increased risk factors wouldn't have existed if it weren't for these denial of opportunities and general anti-trans stigma, and they work in a cycle. So when we're looking specifically at intimate partner violence and sexual assault, in the face of discriminatory treatment, whether it be from law enforcement, from medical providers, in shelters, or when accessing other services, many trans survivors of intimate partner violence, domestic violence, sexual assault might be hesitant to seek help, or definitely like trying to avoid law enforcement or medical treatment or services because they fear additional rejection or violence due to their identity. So 54% of trans folks report having experienced some form of intimate partner violence, and 47 reported having experienced sexual assault or sexual abuse. And since 2013, 29% of known cases of fatal violence against trans people were committed by an intimate partner. We also, when we're talking about intimate partner violence and sexual abuse experienced by trans folks, also need to keep in mind their engagement in survival sex work. This is something that not folks do, and I think it's something that people stereotype a lot, but some folks, because of lack of opportunities, denial of opportunities based on their identities, often feel like they need to resort to engaging in survival sex work to survive. So engagement in sex work and the current criminal status of sex work are intrinsically tied to the epidemic of violence that impacts trans folks. So trans and gender nonconforming people who do engage in sex work will definitely face higher rates of intimate partner violence and sexual assault in comparison to cisgender heterosexual folks. So trans sex workers who face criminal charges might be prevented from securing housing or other employment opportunities or benefits because of these criminal charges that they face in addition to their gender identity. And then due to the fact that sex work is still criminalized, many trans and gender nonconforming sex workers try to avoid interactions with law enforcement and decline to seek assistance when they are, survivors of traumatic experiences or crimes. So now that we've discussed the epidemic of violence against trans folks, we talked a little bit about the barriers that folks face, and in particular, we discussed how the healthcare system is a part of that. We're going to talk a little bit more about the trans healthcare system, or the way that we provide care to trans folks, and a little bit of the history of the medicalization of trans identities. So I want to start us off by giving a brief timeline of the pathologization and medicalization of trans identities. So starting us off in 1949, sexologist David Caldwell coined the term psychopathia transsexualis. So it was essentially just a term to describe individuals whose gender identity didn't align with the sex that they were assigned at birth. In 1966, another sexologist, Harry Benjamin, published the transsexual phenomenon. So this was one of the earliest texts that pretty much attributed transsexuality to mental illness. And then this is kind of where the pathologization of trans and gender nonconforming identities began. In 1980, transsexualism was debuted in the DSM. So this was kind of the official classification of transsexuality and gender nonconformity as a medical disorder, specifically here in the US. And then by the time that it was 1994, the DSM-4 changed, the last one was DSM-3. This is DSM-4 in 1994, changed transsexualism to gender identity disorder in adults and adolescents. So when this happened, activists tried to argue against this new diagnosis because it shifted the focus from a person's performance of gender and their gender expression to their identity and personhood. And it, implied that the individual was mentally disordered and in need of treatment, in need of a cure. And then by 2013, in the DSM-5, gender identity disorder was changed to gender dysphoria. So this is where the definition and a lot of the criteria for gender dysphoria changed from what it used to be. So it was defined since 2013 as a marked incongruence between one's experienced or expressed gender and assigned gender. So we'll talk a little bit more about what this means, but I first want to give some questions to you all to consider as you're listening and reading along on the screen. So first and foremost, how do these diagnostic criteria function to produce and maintain binary structures of gender, and how does it impact the lives of gender nonconforming individuals? How do regulatory criteria enable medical institutions to determine what it means to be trans and gender nonconforming? And how does this inevitably function to gatekeep trans and gender nonconforming individuals from seeking medical care? So I want to start us off by reading a quote from the book White Tears, Brown Scars, How White Feminism Portrays Women of Color by Rumi Ahmad. This is on page 77, 55 in a PDF that I can share to all folks if they're interested in reading this book. But this is a quote from this book. It reads, "Binary oppositions, oversimplified as they are, leave no room for individual distinctions and complexity. The existence of a binary means that one pole in the structure is almost always going to dominate." So when we're thinking about the gender binary and the implications of gender binaries in medicine, I think oftentimes this argument was started with, what's normal versus abnormal? Does gender binary imply that something is abnormal? So what does the phrasing of gender incongruence imply about gender identity, right? We understand that since 2013, the definition or part of the criteria for gender dysphoria that then allows you to have access to gender affirming care in many states, in many cases, is, having gender incongruence, right? The feeling that your gender identity is different than the sex that you were assigned at birth. So the production of a binary gender implies that any gender identity that deviates from this normal description is unnatural and pathological. So similarly, when we're thinking about gender incongruence, this suggests that there's a normal and a natural state of congruence with one's individual gender that trans and gender nonconforming people deviate from. So medical authority has often presented sex as a binary. We understand this, right? This is a social construct that was created. So in medicine, a lot of times, sex is still viewed this way, gender is still viewed this way, right? Someone is either male or female. But we understand, right, the existence of individuals with intersex conditions, as well as the presence of both male and female sex traits, including genitalia, gonads, chromosomal traits, demonstrates that these binary categories of gender don't neatly differentiate humans by sex traits, right? Even in medicine, you can't really say that there's just male or female when intersex folks exist. But regardless of that, sex is commonly used as a marker for interpreting gender. And gender binary reinforces the belief that gender must correspond to those two sexes, where males are expected to be masculine and females are expected to be feminine. So this inclusion of gender nonconformity in the diagnostic manuals and the outline criteria for diagnosis sets and the framework for defining trans identities through a medical gaze. So we'll talk a little bit more about the medical gaze in the next few slides. But in other words, this pretty much meant that medical institutions determined who was trans based on the criteria in the DSM and in other manuals. So this included like who was eligible for medical care, such as hormone therapy and other gender affirming surgical procedures. So the inclusion of gender nonconformity in diagnostic manuals and the outlined criteria for diagnosis sets and the framework for defining trans identities pretty much exists through this medical gaze. So medical institutions essentially get to determine who's trans according to the criteria and are thus responsible for deciding who's eligible for medical care. So for example, a criteria in the DSM that exists to this day is gender dysphoria. So this is defined as a strong desire to be rid of one's primary or secondary sex characteristics because of a marked incongruence with one's experienced or expressed gender. But the caveat here is that some trans folks don't desire any surgical intervention at all. Some people think that it's anticlimactic or that they don't have to have, sorry, my cat is in the way, that they don't have to have a cure, so to speak, through this medical gaze to exist as they are. So this kind of gave way to the wrong body, right mind stereotype. So gender dysphoria is often framed as needing a cure, right? That you're born in the wrong body, you need to correct that. So the dominant narrative here is that trans person is trapped in their wrong body who in the process of undergoing psychiatry will be diagnosed as gender dysphoric, undergo hormonal treatment, have surgery, and then arrive at their new sex, at the destination of their new sex. So while these versions of the trans self may make sense for some people, right? It might make sense for some people feel comfortable and okay describing their journey as a trans person and their experience as a trans person in this way. But this doesn't really leave room for the possibility of being trans or of identifying as non-binary. So this is kind of where it gets a little muddy. So the medical gaze works really hand in hand with transnormativity. So if you've all heard the phrase heteronormativity, this is essentially the same thing, but with trans identities. So the medical gaze views trans patients as either successful or unsuccessful based on how well they adhere to gender binaries. So for example, if a trans woman presents as feminine or passes as a cisgender woman and engages in romantic or sexual relationships with a cisgender man, through the medical gaze, this trans woman is seen as successful. But because of this definition, or because of this view through the medical gaze, this pretty much leaves all other trans individuals who don't reinforce gender binaries and medical models of transitioning as unsuccessful. So now we're going to talk a little bit about reproductive care as being a component of gender affirming care. So just like cisgender folks, trans people can have sexual partners of different gender identities, right? They don't necessarily have to have a partner of a different gender than their own. Trans people need preventative healthcare screenings as well as cisgender folks. Trans folks are also at risk of HIV and other STIs. Trans men and other gender expansive folks who are assigned female at birth are also at risk of unintended pregnancies. So reproductive care is not just for cisgender women. So some recommendations to improve transgender sexual and reproductive health are here. So follow accepted medical guidelines. This one is kind of depending on the state that you're in and what this looks like for some trans folks. But generally speaking, sexual and reproductive healthcare providers should become familiar with clinical guidelines and recommendations for trans folks from, their places such as the World Professional Association for Trans Health. You can also adopt policies of respect and non-discrimination. So respecting each other's gender identities within your workplace, as well as those of their patients. You can also train staff on cultural competence and non-discrimination. You can incorporate trans inclusion in grant guidelines when you're talking about expanding, the finance in your department, in your office, in your, clinic, or wherever it might be, in order to provide and expand the services that either don't exist or need to be expanded in your field of work. Always report discrimination whenever possible, whenever you feel comfortable doing so and you feel safe doing so. Right? We never want to put anyone at risk, but we definitely want to make sure that folks are reporting whenever possible. And then also eliminating public policies that require sterilization procedures for trans folks. So policies requiring trans folks to undergo sex reassignment surgery or gender affirming surgery before changing their gender marker on government documents tends to violate a lot of their reproductive rights and frequently amounts to forced sterilization. So making sure that these policies are updated, whether if you're in the public policy world, definitely something that you can work on and can be an advocate for. But then thinking generally of everything that we've talked about, what it means to be a trans person and through the medical gaze, how the medical system views you as a trans person, how can we provide affirmative care for trans and non-binary patients? How can we provide gender affirming care? So asking for pronouns and introducing yourself with your own pronouns is definitely a great place to start when you're working with patients. Emphasizing, the individual's self-determination and autonomy, right? Making sure that they understand and you're sharing with them that these are the options that you have with gender affirming care, but you do not need to feel obligated to undergo anything if that's not something that you're seeking, right? If there's someone who says like, I'm trans, but I know there's something about, the gender affirming surgery or hormone therapy that I don't really feel like comfortable, or something that it's something that I want to do. You can say, okay, that's fine, right? You don't have to do anything that you don't want to do, right? It's your body. You can still make a choice about, the gender affirming care that you undergo. Number 3, clinicians and staff should make direct and non-judgmental inquiries about a patient's experience and feelings before applying any labels. So this, obviously asking for pronouns and introducing yourself with your own pronouns, but then also avoiding to dead name a patient. And then number 4, development of inclusive and compassionate protocols for the care of trans patients, as well as roadmaps for their families. So specifically, this is really, really important for trans youth. We want to make sure that they feel supported. As we mentioned earlier on, one of the biggest ways that folks experience anti-trans stigma is familial rejection. So making sure that folks have policies or at least some protocols to help families as well as their trans patients, go through the gender affirming care experience and talk to their families is always really great. And then number 5, this is a work in progress and something we can all do together as we're working in these fields, but we can always reconceptualize outdated terminology and the way that we view gender affirming care in our trans patients. So discussing uteruses, ovaries, penises, and other body parts without assigning them a gender, using phrases like internal or external reproductive organs instead of like women's reproductive organs or men's reproductive organs, using language such as people who menstruate or people who are pregnant or people who produce sperm, using cisgender rather than biologically female or male. And then, for example, if we're looking at a specific case, we can take endometriosis as an example. So when we're discussing endometriosis as a system-wide gender disability that impacts organs, nervous system, cognitive abilities, mood, respiration, circulation, and digestive functions, as well as a reproductive system, we're framing this in a way that is more gender inclusive. Okay. I know we're running a little short on time. I have a few minutes left, so I'll try to go through the last bit here relatively quickly, but I wanted to leave you all off with thinking about trans liberation as an essential component to the way that we provide trans healthcare. So when we're thinking about trans liberation movements, obviously we first really need to keep into consideration the work of past folks, the trans folks that came before us. So modern trans rights and visibility movements have maintained a hyper focus on assimilationist reform via legal protections and representation in the military, which is great, right? It's always great to expand equality and rights in the systems that we exist in, because we're still existing in this system, we're still surviving in these systems. But these are not necessarily things that previous trans activists would have fought for themselves. So the work of queer activists in the 60s, 70s, and 80s called for the abolition of capital punishment, institutional religion, and other seemingly radical demands. So when we're thinking of neoliberalism and transnormativity, I mentioned transnormativity as being a part of how folks are viewed, trans folks are viewed through the medical gaze. We're referring to the specific framework. Sorry, my cat got in front of my camera. So transnormativity specifically describes the specific framework to which trans folks' presentations and experiences of gender are structured in such a way that is dependent upon medical standards and also their ability to pass as a cisgender person in society. So transnormativity is a constraining ideology that either legitimizes or rejects the existence of trans folks based on whether or not they fit society's understanding of a normal trans person, or how good they align with the gender binary. So we really want to make sure that we move away from this form of thinking, because not everyone is going to neatly align into a gender binary regardless of whether or not they transitioned. So definitely something important to keep in mind as we're providing care to folks who are trans and gender nonconforming. But the struggle for trans liberation is part of various different struggles that are all intertwined. Like, one thing that I can continue to emphasize is, right, trans violence exists and is compounded and compacted with other systems of oppression as well. So the struggle for trans liberation is also part of the class struggle. So in the colonized West, the standard for a normal life is not only cisgender, or as close to cisgender as you can get if we're thinking about transnormativity, but also white, middle or upper class, able-bodied, and heterosexual. So normal is pretty much coded language for a body that is able to work and produce at a satisfactory rate for the capitalist system. And because of neoliberalism and transnormativity, we're presented with this sort of illusion of equality through representation in mainstream media and inclusion in historically harmful systems like the military. Meanwhile, most of our vulnerable communities that need tangible resources are still lacking those resources, right? They continue to suffer from houselessness, from harassment, from violence, and are often, murdered and victimized on the streets and wherever else they may exist and navigate through their lives, because, these historically harmful systems still exist. So I really like to think of abolition as a central component of queer and trans resistance and the way that we navigate through medicine and how we treat trans folks. So it seems from an outside perspective as not super aligned or super connected, but it definitely is. So there's really no trans liberation without prison abolition. So the movement of trans liberation has always had abolition at its core. So our current historical and ongoing crises of policing and racialized violence without a doubt overlap with the abuse and harassment that trans people, who many are trans folks of color, face in their interactions with police, both in the 60s, 70s, and 80s, and even now. So prisons breed violence and are harmful to these capitalists, and are harmful to those capitalism deems undesirable. So folks who are trans, folks who are non-white, who live in poverty or are low income, queer and trans folks, folks with disabilities, immigrants and refugees, and other marginalized individuals are the ones who are deemed undesirable through a capitalist system and are thus more at risk of violence when going through the prison industrial complex or engaging with law enforcement or other forms of systemic violence through the legal system. So LGBTQ plus liberation definitely has a very, very close history with abolitionist movements. So if we're thinking about Stonewall, for example, so the annual Pride celebrations that we celebrate in June mark the anniversary for the Stonewall Rebellion. So in June 1969, at a bar called the Stonewall Inn in New York City, queer and trans folks fought back against police brutality and violence. So this is just one example of the way that these kinds of liberation movements have always had a very close history with abolitionist movements. So I want to read out this quote to you all from Dean Spade. Dean Spade is a trans author, professor, activist who talks a lot about how trans liberation movements and trans activism is very deeply rooted with abolition. So he says, "We are abolitionists because we know it is not a broken system that needs to be fixed. It is a system operating exactly as it was designed to operate, and hurting people it has always hurt, and it needs to be dismantled." So I'll leave you all off with this, right? We understand that trans liberation is intrinsically connected to all leftist liberation movements. So trans liberation and LGBTQ plus liberation movements more broadly are inextricable from other leftist liberation movements. So feminist movements, migrant justice movements, Black liberation movements, disability justice movements, and tons others. So while all these movements imagine another world where all people have what they need, no one is exploited for the benefit of others, and we don't live with the fear of law enforcement or criminal justice figures. We also know that it's going to take some time to work through this, but that's why we're doing the work that we do. So thank you all so much for giving me the time to speak with you all. Like I said, my name is Alexia Sambrano. My pronouns are they, them, theirs. I'm a violence prevention educator with the Relationship and Sexual Violence Prevention Services Unit at Southern California. And I've listed my emails there on the screen in case anyone has any questions or would like to stay in touch.
Thank you so much, Alexia. That was really great. I really enjoyed listening to your presentation and hearing everything that you had to share with us. So I really appreciate you taking the time to be here with us this morning. Next, I'm going to pass it on over to Dr. Candace Burton, who's going to also be talking to us about the work that she does with the LGBTQIA plus community. So Dr. Burton, I'm going to pass it on over to you.
Great, thank you. Let me just pull my slides up here. Let's see. Of course, as soon as I do that, all the windows move around on the screen. There we go. So I apologize for not having my camera on. As I told the folks who were here earlier, I am moving this week and I am an absolute mess. So enjoy my headshot because the real me at the moment is not nearly so nicely put together. I also wanted to thank Alexia for that awesome presentation, and I would love to get a copy of your slides if you don't mind sharing. There's some great information in there, and you'll see a lot of that reflected here. So I am what's called a forensic nurse, and that means that I work with victims of sexual assault, domestic violence, other kinds of interpersonal violence, where someone's body becomes a carrier for evidence. And so these slides are based on that perspective, but they apply to providers across the board in terms of advocacy and healthcare. So here are our objectives. I want to talk about the intersection between cultural safety and trauma. I want you to understand how to use appropriate language. Thank you, Alexia, for getting us started on that already. Identify, that should just say care modification. SANE stands for Sexual Assault Nurse Examiner, which is what I usually am talking about. But again, this applies to any provider. Culturally safe care for LGBTQIA patients, and to describe 2 actions that you can take to utilize trauma-informed approaches when working with LGBTQIA folks. Okay, there we go. I just wanted to share, I, until very recently, worked for the Steubenville Gross School of Nursing at the University of California, Irvine. I have recently moved to the University of Nevada at Las Vegas, but I wanted to share our diversity statement, which I helped write at UCI. We are committed to a culture of integrity, respect, equity, diversity, and inclusion for all. We acknowledge that we live and work on the appropriated unceded lands of the Kizia and Tongva people. We acknowledge the universality of implicit biases about various personal characteristics such as race, ethnicity, gender, and sexuality. socioeconomic status, religion, and ability, and we are committed to preventing their influence on our culture. We therefore encourage collective reflection, self-awareness, and openness to change that advances inclusive excellence, and we support open and honest dialogue about our learning and working environments. Okay. So much like what Alexia just said, this is meant to be a safe space for talk, but also a brave space. Please take a time out if you need to, if anything is getting overwhelming or too intense. Remember that you can't fix everything. I know that so many of us who work in the healthcare and other kinds of caring professions often would like to fix everything for our patients and clients, but we can't do that. And I just want to remind you that that is still the case. But please ask for what you need. If I'm talking too fast, if you have a question, if there's something I'm missing or something that I just plain got wrong, please tell me. So when I think about how we provide care for LGBTQIA folks, I think about this intersection between trauma and what's called cultural safety. So when we are caring for people who are already marginalized in some way, we need to create a space wherein their safety is assured and reinforced. And that's what cultural safety is about. So first I wanted to share a definition of trauma, and then we'll talk more about cultural safety and what that is and how we can create it for LGBTQIA folks. This is the SAMHSA definition of trauma, and they have 3 E's. I actually think there's a 4th E now, but I need to update my slides. but the 3 E's are event, experience, and effect. An individual trauma results from an event, a series of events, or a set of circumstances that are experienced by someone as physically or emotionally harmful to the point of being life-threatening, that have lasting effects on their functioning and their mental, physical, social, emotional, and spiritual well-being in multiple dimensions. So when we talk about trauma, we're talking about things that affect people in an ongoing way. So trauma is not just an emotional event. It is also not an acute event that is then over. It is not a sign of weakness, a lack of coping skills, or any kind of failure on the part of the traumatized person. And it's also not just in your head. If you are familiar with Bruce McEwen's work at all, he was a neuroscientist who developed this theory of what's called allostatic loading. So for the non-clinical folks in the audience, just bear with me here. If you remember your high school biology, you remember that your brain is connected to something called your hypothalamic pituitary axis, the HPA axis. I apologize to the ASL interpreter for having to sign all that. So the HPA axis activates your stress response. So allostasis is stress. Okay, so homeostasis, if you remember your biology, is when your body's just doing what it does. Everything's fine, there's no illness, there's no stress, everything is proceeding as usual. Allostasis is when something happens, okay? And it doesn't have to be a violent event, it doesn't have to be explosive, there just has to be that perception of threat, that feeling of helplessness or needing to be vigilant. All right, and so what McEwen proposed is that allostasis, when someone is under chronic stress, it doesn't shut down. So it should shut down, it should be temporary. It's meant to be sort of a coping mechanism for when something happens. But when you are part of a marginalized group, have been traumatized, have experienced violence or abuse, it doesn't stop, particularly if we're thinking about someone who's in an abusive relationship that's ongoing. So there's no pause, there's no stop in that activation of that stress response. This means a couple of things. One, it means that at some point your body starts to burn out all the things that it uses to create that stress response. You start to run out of all the proteins you need. This is where we see people who can't eat when they're stressed, or they feel nauseated, or they eat too much because their body is trying to replace or cope with what's missing. Okay, everybody responds differently to stress, and obviously we want to make sure that our responses are inclusive and thoughtful when we're talking about traumatized folks. But it's important to understand that allostatic loading is a physiological process. So trauma is not just something that happens to you emotionally or in terms of your mental health, okay? It has an effect on your body. And we have research to show that it actually affects you at the cellular level. I won't get into that because it's a little technical, but it causes derangement of some parts of DNA, which is why we see people with who have been under lots of stress, chronic stress, with problems like chronic pain or weight gain or cardiovascular health problems. There are many types of trauma, and I want to talk about all of them, or at least some of them, because it's very important to consider that when someone is traumatized acutely, say that someone has just been assaulted, they are also carrying with them all of the other kinds of trauma that came before that event. So we may see people present to us acutely because something has just happened to them. But there is also a whole other set of dimensions that we need to consider when we are trying to provide trauma-informed care for them. So there's historical trauma. Historical trauma affects the history of a specific population or community over generations. Native Americans, for example. We've shared some land acknowledgements today. So as I think probably some of you know, there is a very high incidence of domestic violence, as well as alcohol and other substance abuse among Native American populations. And that is almost certainly related to the historical trauma of what happened to those people. Structural trauma is the harm done by social structures that value one set of characteristics over others or disempower people who do not have those characteristics. So things like racism, ageism, ableism, cisnormativity. Of course, there's violence and abuse. I think we all know pretty well how that plays out. And then there's also something called betrayal trauma. And betrayal trauma interacts with almost all of the other types, because betrayal trauma is the trauma of having someone or something that is supposed to support you, care for you, provide for your survival, fail to keep you safe. So when we're talking about people who are in abusive relationships or people who were abused as children, someone who is supposed to love you and care for you is hurting you. So not only do you have whatever the physical trauma that is, but you also have this secondary betrayal trauma that adds into that. And all of this contributes to allostatic loading. And so when someone comes to you and they have one of these other types of trauma in their background, plus whatever has brought them to see you, you are dealing with multiple layers. And to create cultural safety, we have to think about those layers. Trauma is the absence of safety. So I just talked a little bit about betrayal trauma. Cultural betrayal trauma is when someone's cultural needs are not being fulfilled by people or institutions that they depend on, and those institutions fail to provide for their safety. So in the context of violence or abuse, betrayal happens by whoever the assailant was, but then also there may be problems with the systems meant to help the survivor. That's called re-traumatization. And this is what happens very often when someone reports to the police that there are things that they have to go through, that there are things they have to deal with that actually cause more trauma rather than helping them get through that and move forward. I love this quote from Bessel van der Kolk. The Body Keeps the Score is a wonderful book. It's many years old now, but it is specifically about what trauma does to the body. And this quote, I think, encapsulates everything that I was just trying to explain as we move forward. Being traumatized means continuing to organize your life as if the trauma were still going on, unchanged and immutable, as every new encounter or event is contaminated by the past. And that really captures that layering of trauma that I was talking about. And when we're dealing with marginalized populations, it's absolutely vital that we keep in mind how that marginalization, through whatever has caused it, whether it's a structural or historical type of marginalization, contributes to their experience of whatever trauma has brought them to us today. So we're finally going to get to the good stuff. This is the cultural safety model, and I cannot recommend the book that this came from highly enough. It's down there at the bottom. It's called The Clinician's Guide to LGBTQIA+ Care. I actually know Ronica Mukherjee tangentially, and I just am thrilled with what they've done with this book. It's a very skinny little book. It's very easy to read and keep handy for referring to things. But this diagram comes directly from that book. And so you can see that we start down the chain of things that need to happen. Cultural safety incorporates partnerships, consideration of something called personal ADLs, which means activities of daily living, and I'll explain what that means shortly, centering of the patient, and our own personal self-reflection about what we expect from people who are part of marginalized groups. So if you look at the diagram, we start down at the bottom with the patient's culture, the complex, multi-layered parts of being LGBTQIA, including all of the things that we just talked about that could cause trauma for someone in another way: race, class, incarceration, disability, etc. Then we move outward to our own cultural sensitivity and awareness, the knowledge that there are differences, but also accompanied by a willingness to learn and to understand and to function with people, not around or over them. And so you see the two bluish colored arrows pointing off in different directions. So that's at the point where we begin the process of centering the patient or the survivor who's in front of us to reach their goals. We also need to understand their personal activities of daily living. Now, in the medical field, we refer to activities of daily living as just the stuff you do all day, like laundry and walking upstairs and feeding yourself. These are all things that tell us how someone's functioning. Personal ADLs are the things that you need to do to keep yourself safe in a day. I have an exercise that I always do with my undergraduate nursing students. And I ask the room, okay, for the men in the room, because there's usually a few, even though nursing is still very much female identity dominated. I ask for the men in the room, what do you do on a daily basis to keep yourself safe? And there's just crickets. Eventually somebody will say, lock my door. And then I say, okay, for the women in the room, what do you do on a daily basis to, and I never even get to finish the question because the room blows up. Don't walk alone, have $20 on you at all times, carry your phone, talk to somebody when you're walking to your car, park in a well-lighted area, lock your windows and doors. They just go on and on and on. Those, and the men are looking around like, what? Those are personal ADLs. Those are the things that we do to keep ourselves safe because of who we are, not because we're in a particularly dangerous situation. You're not walking through, downtown Beirut, but how you navigate the world yourself. There's a professor at UCI who refers to navigating one's blackness. He's an African-American studies professor. And I think that is a clear indicator of how important these personal ADLs are. So we need to understand that when we're interacting with folks. Cultural competency is where we achieve the knowledge acquisition and the training that we need in order to provide cultural safety for LGBTQIA patients. And then finally, being able to transfer power to the patient as defined by their own comfort in the setting. So we prioritize their narrative, and we need to partner with community groups who can provide specific supports for LGBTQIA folks. So that's the cultural safety model. How do we implement that? So the first thing is to engage in partnerships with our clients and with our community. Partnerships are a balancing of social capital. Social capital is how much influence or safety you have in your social realm. So it includes things like whether you feel like you belong, whether you feel like part of a community, whether you feel safe in the environment, whether you feel heard, reciprocity, participation, feeling like you are part of something larger. So when we are thinking about creating cultural safety for our LGBTQIA survivors, we need to think about how is their social capital tied to their personal ADLs and what they need to do to take care of themselves in this traumatic situation. Consider those personal ADLs. What do they need to do to get through a day? How do they provide for their own safety? And what kinds of things are traumatic on a daily basis anyway? So I think Alexia was talking briefly about having a kind of welcoming environment. If I am a LGBTQIA person and I walk into a new healthcare setting and there are pamphlets on heterosexual sex and there are pictures of heterosexual couples on all the walls, and there's papers, pamphlets and things of information about that would apply to heteronormative couples, I might feel a little threatened. I'm not going to feel comfortable, and that could be traumatic. If you've had, because as Alexia pointed out, so many LGBTQIA folks have had really crummy experiences with various systems. Okay. Step 3, prevention of harm. Again, this reflects exactly what Alexia said, no judgments. Thinking about harm reduction. Sometimes we can't take someone out of a situation, but we need to help them figure out how to be safe in the situation. And also trying to avoid that re-traumatization. We want to align our goals and engage in advocacy with our patients. Many of you do this already. But again, harm reduction for this person. You can't snap your fingers and make somebody stop using cigarettes or alcohol as a coping mechanism. But can we find a way to keep them safe if they need to do that for their own comfort? Purposeful self-reflection. This is where we have to think about our own perspectives. So first of all, how much experience have you personally had caring for the LGBTQIA community? What does it mean to be gender affirming? What are the differences among being bisexual, pansexual, lesbian, gay, queer, non-binary, intersex, aromantic, or asexual? These are all very different things. What pronouns are correct for someone? What are you going to do if you misgender somebody or use their dead name? How are you going to feel if you find out you got it wrong? I accidentally misgendered someone recently because I was taking a mediation training and I was in a role play situation and somebody else had referred to them as she, and I was repeating what that person said, even though I knew that the person they were talking about's pronouns were they. And so as soon as we finished the role play, I turned to them and I said, I am so sorry, I got your pronoun wrong. And they were very gracious about it. So that is an example of what to do when you get it wrong. If you get it wrong and you know you've gotten it wrong, apologize and move on. If you get it wrong and someone corrects you, apologize and move on. Don't carry that around with you. Don't become defensive and don't assume that they think poorly of you. It happens. Quite honestly, when I was about 13, I was tall and skinny and had short hair, and I got misgendered a couple of times. So you just apologize and move on. That's just what we have to do. So we have to think about, how do we feel? What do we think? How are we reacting to someone? And now I'm going to just give you a whole bunch of vocabulary, and you're welcome to have these slides. I'll send them along as a PDF because I know it's too big to send as a regular file. But these are just some definitions, words that you might need to know, things that you might need to think about, things that you might not have heard of before. So there's such a thing as barebacking, which is engaging in anal intercourse without a condom, being bigender, a gender identity identified by feeling that one has two fully functioning gender identities, which may be presented differently at different times. Gender, I think we know, gender nonconforming, person whose behavior appearance does not conform to cultural and social expectations about what is appropriate for their presumed gender. Gender fluid, gender queer, people who fluctuate along a spectrum or who do not describe to conventional gender distinctions and may identify with neither, both, or some combo of everything. Heteronormativity, Alexia touched on this. This is the idea that everybody is part of a gender binary and that heterosexual orientation is normal to the exclusion of any other identity. HIV, AIDS, HPV, I think we all know what those are. Intersex is a general term for a variety of physiological conditions in which a person may have a reproductive or sexual anatomy that does not align with what the textbook would say is traditional cis male or cis female anatomy. Non-binary genetics, people who have sex chromosome arrangements other than XX and XY. Alexia touched on this as well. Genetics are nuts. I studied genetics for a while a few years ago, very in depth. And it turns out that it's a wonder that anybody is walking around breathing, because our genes do all kinds of weird things that we don't even usually know about. So there can be people who are XY, but who present as female. There can be folks who have XYY genetics. There are also other kinds that are incompatible with life. There's lots of different disorders that are linked with having sex chromosome abnormalities that other than XX or XY. But the point is that there is no such thing as a biological gender or biological sex. You can have all kinds of things going on in your genetics. Pansexual is a person who's not limited in their sexual choice with regard to biological sex, gender, or gender identity. And polyamory, of course, is the practice of engaging in multiple consensual sexual relationships. Whoops. There we go. Queer is an umbrella term that's used for sexual and gender minority. It was used as a pejorative in the past, but a lot of people now see it as an empowering way to identify themselves. Questioning, always with an asterisk, because it just means don't know, figuring it out. Sex, STIs, we know. Trans, I always prefer to use trans with the asterisk here because that encompasses anybody who has a non-conforming gender identity or expressions, rather than always using transgender, because transgender can be very limiting in terms of gender binarism. So we use trans with an asterisk to include everybody. So again, Alexia beat me to the punch on this, but thinking about culturally safe care for LGBTQIA survivors, 90% of reported hate crimes are committed against LGBTQIA folks. 40%, a little over 40% of these interacted with law enforcement, and 60% of those who did had a bad experience. Either they were dismissed or treated with hostility or whatever. Trauma, it comes from healthcare as well. Alexia touched on the history of considering LGBTQIA folks mentally ill. Up to 70% of this community has been refused care, had a provider refuse or require excessive precautions like lots of gloves and gowns and all kinds of things, been verbally or physically mistreated by a healthcare provider. That last thing is sometimes called sanctuary harm, otherwise known as betrayal trauma, when you seek care from someone who then reacts to you in a way that makes you feel traumatized. So this is part of what's coming in with someone who is part of the LGBTQIA community and has had a violent or abusive experience. All of this is walking in with them in addition to whatever has happened to them. So we need to practice trauma-informed care. We need to take a trauma-informed approach. And if you recall, we had the 3 E's earlier, we now have the 4 R's. So a trauma-informed approach realizes that pretty much everybody is traumatized and takes what we call a universal precautions position. In the medical world, universal precautions means that we always wash our hands and we always wear gloves when touching a patient. It means some other things too, but that's the basic idea. And so we just assume that everybody's traumatized and we treat them accordingly. We create cultural safety for them in whatever way is necessary. Recognizing how trauma affects all individuals involved with the program, organization, or system, including us as the providers. We have to deal with our own trauma, and we have to realize that we can be affected by things like vicarious trauma or secondary trauma, and that we need to heal ourselves as well. Responding by putting all of this knowledge into practice, and then resisting re-traumatization, looking at our policies and our procedures and asking, is there the potential for re-traumatization if we continue to proceed like this? So everybody always wants to know, so what do I do? How do I create this culturally safe environment? How do I engage in trauma-informed care? The first thing you got to do is not be in a rush. And you need to look at the person. Sometimes we've got 7 things on our desk and somebody comes in and we're looking over here, but we're talking to them, and you're looking at something else. You got to focus on the person in front of you. You have to make them feel safe. You need to talk to them about any concerns or procedures before doing anything. When I give this talk for sexual assault nurses, I talk about the fact that you should always tell the patient before you touch them. You should always tell them how you're going to touch them and where. So engaging with people and asking them, okay, if I am going to, refer you to this service, is that going to work for you? Or if I am going to try to get you into an appointment with a therapist, do you have concerns about that? Make sure that that person has as much control and choice as possible, because as I always tell my sexual assault nurses, they've already had their agency taken away from them once, so let's not do it again. Validate their concerns, let them be however they are, and that's understandable and normal. People react to things in different ways. If they want someone with them, I know sometimes we get hung up on confidentiality, but if they want someone to be with them, great, let's have someone with them. The caveat with that is that sometimes it can make it harder for the person to actually express themselves if it's someone that they care about who is worrying about them. So always try to navigate that as best you can while giving the person the option. Be mindful of and acknowledge any stress reactions as normal. And once again, assume that everybody probably has some kind of trauma and treat them accordingly. Oops, here we go. Ask, what can I do to support you? What is your preferred outcome? What would you like to happen? Offer, would it be helpful for me to connect you with this agency or connect you with this service or help you fill out this application? Engage with them. How do you want to do X, Y, Z? If the goal is for them to get out of their living situation, how do they want to do that? Remind them that you are there to support them and that you would like for them to be honest with you, because sometimes people are very leery when they have been traumatized by systems in the past. So when someone is coming to us seeking help, they're entering into a system we are part of, and making sure that they understand that you are present and available for them, and you are not going to judge them or take away their ability to choose. And that's really all I have. These are my references for everything that I've just shown you. That top paper is one that I wrote. It has that entire table of vocabulary that I shared with you in it. We wrote that for nursing educators to teach our students about how to attend to the health needs of LGBTQIA folks. So all of this is good stuff. Again, I highly, highly recommend The Clinician's Guide to LGBTQIA+ Care. It's a fantastic book. It introduced me to the concept of cultural safety. And obviously I have been preaching that ever since. As I said, I've recently moved to the University of Nevada at Las Vegas. So this is my email. Please be in touch if you have questions, comments. I will make sure that these slides are available for you as well. And I thank you very much for your attention and for coming today.
Thank you so much, Dr. Burton. That was wonderful. It was really great getting to hear everything that you had to share with us. And it was really wonderful seeing how your and Alexia's presentations really complemented one another. So I appreciate both of you being here. We do have a few minutes left, so I'm wondering if there are any questions from the audience, if Alexia and Dr. Burton don't mind answering them. Just want to offer up that space to everybody. So are there any questions? Alexia or Dr. Burton, anything that you would like to say to the group in closing after hearing one another's presentations?
I just want to thank Alexia again for giving us such a great overview of trans health and healthcare. That was one of the best presentations I've seen on that, and I really appreciate the time and effort that you put into that.
Thank you, and likewise, I really appreciated hearing what you had to say as well. It's always really, really important to get some more information on how to provide care and how to interact with patients and other folks, whether it be in a workplace setting or just in general life. So thank you so much, and also thank you for having us. It's a wonderful space, and I really enjoyed being here.
Thank you. Yeah, and you're getting some show of appreciation in the chat as well. I hope that you're both seeing that. So again, the space is here. If folks have any questions, we can hang around. Otherwise, thank you everybody for participating and being here today. I think it was a really great space, and I'm really excited that we got to talk about this topic.
I'll ask a question.
Go for it.
So a lot of us who attended, obviously, because like we care about the issues, when we are out in the field or when some of the people that we work with are maybe going into other spaces that maybe haven't heard this information before, and then we're kind of passing along or educating fellow colleagues or partners. What are some tips about navigating that?
I think at least one thing I can recommend, or something I've done in the past, is always just having open conversations. One of the things I know I included on the slides there was, to update policies and procedures in your own offices, train, the folks in your teams. So that's always a good starting point, before, it could be at the beginning of every fiscal year or something, you can start a training and just say, like, this is, some standard information we want you all to have before you go into the field and work with, your patients and other folks in the community. Give them, general information, resources, tons of books, PDF files, research articles is always a great start. That way you can give them the general baseline information, and then they can explore and see what interests them, and learn more about specific communities or specialties, or other facets of the work that we do.
Great.
I would agree with that, absolutely, especially about having open and honest conversations. It can be very scary for people to admit their biases and to question their biases. And so I think that in addition to making sure that we're treating our patients and clients appropriately, we need to be gentle with each other, and make it such that we can share when we realize, uh-oh, I have a problem.
Thank you.
So we have oh, go ahead.
Oh, I have a question. Would there be any recommendation with your experience in, let's say, an IPV situation? There's many standards of safety planning that can be found on different types of apps, things like that. What would your recommendation be in honoring our LGBTQIA plus community? Do you have any? Do you use any? I'm just really curious about that. Thank you.
There's a great agency that's, they used to be called the Northwest Network. I think they were one of the first IPV agencies to specifically serve people in LGBTQIA relationships. I think they may have changed their name, but if you Google the Northwest Network, you should be able to find it. They have a wonderful website that has great tools on there.
Okay, thank you so much.
They taught me one of the most powerful things I ever learned about coping with IPV in the LGBTQIA community, because this is 20 years ago, 30 years ago. They said, okay, so even if you're out of this relationship, what are you going to do when you see them again? Because it can be a very small, very tight-knit community, and getting completely out of it means that you have no social support, you have no social circle. So how are you going to handle it when you run into this person again?
Absolutely. Yeah.
Yeah, one thing I would add as well is I think it's called the Bay Area Collective, also has a pod mapping activity sheet. So it's not necessarily LGBTQ plus specific, but it's definitely very helpful in creating pods and seeing, who are like my closest folks that I would reach out to in times of need, folks who can hold me accountable, but then can also provide support if I experience trauma. I think that pod mapping exercise is also a great resource for folks on both sides of that. So it can be for folks who have experienced violence and have, experience, whether it be IPV or other forms of violence or trauma, but it can also be used for folks who have perpetrated violence, for them to also think about, who are the folks that are in my life that I can count on to hold me accountable in these kinds of situations. So it can be used in both ways, and it's a great resource. I do believe it's called the Bay Area Collective.
Great. Thank you so much.
Thank you for that question, and thank you for your question, Kimmy. Any other questions that folks have for Alexia or Dr. Burton? All right, well, I just want to say thank you again so much to everybody for being here. Appreciate you taking the time to listen to this presentation. I think it's a really important topic. To Alexia and Dr. Burton, thank you for both presenting. I think we all really benefited from hearing from both of you and everything that you had to share with the group. I also want to do a thank you to our ASL interpreters for being here with us today and helping us with language access. So thank you everybody so much for being here, and I hope you have a great rest of your day.